Just a quick heads up before we begin. Everything in this episode was accurate when we recorded it, but things move fast in evidence-based medicine. For the most up-to-date and definitive information, then please refer to Red Whale Knowledge. And if you notice anything that might need updating or have any feedback, then we'd love to hear from you. Now, let's get started.
Hello, I'm Fiona Ritchie.
And I'm Nick Kendrew.
We're both part of the Red Whale team.
Come with us as we make your life easier and reignite your passion for primary care.
Welcome to the Celebrity Traitors Has Finished primary care pod from Red Whale. The primary care pod from Red Whale.
Whether it's doing your puns and dens in the glens.
Your action plan with Dan. Hi, Dan.
Hi, Dan, whoever Dan is. Or shouting, well, I never, that's so clever.
We're here if you're yearning for some learning. Woohoo!
And with thanks to 6411 on the text for their contribution, it's Gravity CPD. So grab your preferred drink of choice, your trainers or your dog lead, and here's what's bubbling up as we dive in search of our pearls for this month. Bubbling up this time, managing menopause after breast cancer. A diagnosis of breast cancer is life-changing at any age. Women in this situation will commonly seek our advice, and we really want to help them at this vulnerable time. But for pre- and perimenopausal women, conflicting media coverage over the safety of different menopause treatment options after breast cancer has created a recipe for confusion and frustration for patients and clinicians alike. For these groups, additional considerations include impact on fertility and initiation or exacerbation of menopause symptoms by cancer treatments that induce a hypoestrogenic state. So to make these conversations easier and stop that panicky feeling when you get asked a question that you just don't know the answer to, in this Pearl, we share an article written to support our new menopause masterclass.
We'll also briefly cover ultra-processed food and have a clip from the deep dive into this on Boggled Docs with Hussein and Nick, which features our Red Whale Pearl on UPF.
And bubbling under for next time.
Genital warts, spotting, treating and referring. Still a common presentation in primary care and genitourinary medicine clinics, and depending on where you work and your skill set, you might see these often or actually infrequently. But are you confident in the diagnosis and what can be managed in primary care and what needs to be referred? How about what additional screening should be offered and what advice to give those considering pregnancy? We'll look at BASH's 2024 update and cover all those points.
The word addiction conjures specific images for each of us. Perhaps it's a person struggling to stop smoking in Stoptober, or a person who uses IV drugs. Or perhaps it's a behaviour more normalised and ubiquitous in our society. Alcohol, social media use, gambling, or pornography. All can impact health. We thought we'd share an article on addictive behaviours because there are so many things that we need to know and it's really tricky. But don't worry because we're going to simplify it for you. And back to the top of the list, and our first pearl this month is managing menopause after a diagnosis of breast cancer. And to help me do that, I am joined by Lucy Cox, our women's health lead. Hi, Lucy, how are you doing?
I'm very well, thank you, Nick. Hello, how are you?
I'm good, thank you. This is a really interesting pearl and also very topical at the moment because I'm sure lots of people...
opportune, isn't it?
Yes, very much so. I'm sure lots of people have seen in the press that Davina McCall has recently been diagnosed with breast cancer. And of course, we wish her well. This will be a terrible shock for her and for her friends and family as well. But how do you think that this level of press coverage regarding breast cancer and potentially HRT as well, how do you think that is going to change things?
Well, I suppose we have to see, don't we, how it's sort of handled, whether it's something that's going to be a sort of Jade Goody effect or not. I mean, her diagnosis, as you say, is very sad, and obviously we wish her all the best. And obviously we have no idea whether this is related to HRT or not, because breast cancer is a common disease, unfortunately. And it doesn't really change anything, I suppose, in our consultations we're having with women, insofar as we say the same thing that we've always said for a long time that we know that HRT use is associated with a small increased risk in breast cancer. However, in most perimenopausal, menopausal women who are symptomatic with their menopause, the benefits of HRT outweigh the risks, and that doesn't change. And I suppose with our patients who may be a little bit unnerved by the media coverage and the news, that we can reassure them of this. And obviously the decision to take HRT or not is a very patient-centred one, and it's an individual choice at the end of the day.
Absolutely. Okay, thank you. So let's start with some statistics from Cancer Research UK, and these were accessed this year in 2025, and these really hit home. Breast cancer is the commonest cancer in women. Most cases are postmenopausal, but nearly a third are perimenopausal or recently menopausal, and about 9% are in premenopausal women under 45. So this means that we're probably seeing this quite a lot in our surgery, so we really need a good grasp of it. And that's why we're talking about it right here, right now. Now, I know how time pressured you are, so let's do the work for you. So by the end of this session, you'll be ready for your next consultation about this. And all you have to do is to listen to us and continue with that cup of tea or coffee or whatever you're drinking, or keep doing that fabulous dog walk or run that you're on.
For those women that you've just mentioned, Nick, those pre or perimenopausal women who have been diagnosed with breast cancer, the diagnosis itself is hard enough to cope with. But then you have to add in the impact on their fertility, on their sexual health, on the fact that the treatment for breast cancer can induce a hypoestrogenic state, and then that can lead to sudden onset or worsening of menopausal symptoms. So it is a lot to deal with.
Yes, and I think one of the biggest difficulties for primary care clinicians is knowing where to start with this. We're going to have a patient sat in front of us that we really want to help, but we might freeze or panic because there's just so much to consider. Now, the guidelines say just talking about symptoms can be therapeutic. Now, that feels simple, but it's easy to overlook when you're focused on the bigger picture, such as cancer outcomes, for example.
Yeah, the British Menopause Society recommends referring breast cancer patients to healthcare professionals with an expertise in menopause for counselling and symptom management. And this may also involve liaising with the patient's breast cancer team. But for us in primary care, it's helpful, I think, to open up the conversation, to ask about the nature and the cause and the duration of symptoms they may be having, validating their experience in essence. And that can be of therapeutic benefit and make a real difference, mainly because the patient feels that you're taking them seriously and you're hearing them and coming up with probably some simple solutions that might make a difference.
Yes, and as we'd expect, first-line management options would be lifestyle measures and non-hormonal treatments. HRT is generally contraindicated, but are there exceptions, Lucy?
Yeah, there are exceptions. Hormonal treatment might be considered if first-line management or other management options are ineffective or inappropriate and symptoms are very severe and really impacting quality of life. But this is really only after taking specialist advice, which we'll talk about a bit later.
Okay, so let's have a look at breast cancer treatments now so that we can understand their impact on hormonal status and menopause. The aims of treatment are to remove the primary tumour and prevent local spread using surgery and sometimes radiotherapy. Ongoing adjuvant systemic therapies are also used to eradicate dormant occult micrometastases, and it's this treatment which improves long-term cancer survival. So the choice of treatment now, and most women will receive a combination of systemic treatments. An individualised management plan will be made for them based on their age, the tumour size, grade and genomics, lymph node status and presence of lymphovascular invasion, estrogen receptor status, and HER2 receptor expression. Oncologists may use PREDICT to guide treatment decisions. Now, PREDICT is an online tool which estimates a patient's survival rate based on existing breast cancer treatment data. So let's look at those adjuvant treatments, Lucy.
Okay, so we'll start with chemotherapy. So chemotherapy has a cytotoxic effect on malignant cells, but also affects other body cells. The cytotoxic effect, for example, on ovarian follicles may have a therapeutic benefit for premenopausal women with hormone-sensitive cancer, as it will reduce endogenous hormone production, but it may also increase the symptoms of hypoestrogenism and hence menopause.
Anti-estrogenic endocrine therapy now, and most breast cancers are estrogen receptor positive, so endocrine therapy is indicated in the majority of cases and is continued for at least 5 years. Extended treatment for up to 10 years may be offered on an individual basis. There are two main classes of drugs that are used in this situation, tamoxifen and aromatase inhibitors.
Let's start with tamoxifen. So this is a selective estrogen, and that's estrogen with an E, receptor modulator, or SERM, S-E-R-M, which has antagonistic activity on breast tissue estrogen receptors. So it's offered as an initial therapy to all premenopausal women, irrespective of risk of recurrence. And it's also recommended for postmenopausal women at low risk of recurrence, or those at higher risk who are unable to tolerate the side effects associated with aromatase inhibitors. On to aromatase inhibitors now, and you'll all be familiar with drugs such as letrozole or anastrozole. And these drugs reduce estrogen synthesis in peripheral fat. So hence they're only used for postmenopausal women, really, who have no ovarian estrogen production, only adipose tissue estrogen production. So they're recommended for postmenopausal women at moderate or high risk of recurrence. And that's because the studies show superiority over tamoxifen in this age group. And you can read more about this in the online article, Breast Cancer After Treatment.
You'll also have heard about gonadotropin-releasing hormone agonists, for example, goserelin or Zoladex. They're used in combination with aromatase inhibitors in young women at higher risk of recurrence because they're associated with less recurrence than tamoxifen. Treatment duration is usually 2 to 5 years. Now, don't forget targeted therapies like Herceptin, which is a monoclonal antibody which blocks the HER2 receptor and is indicated for cancers which overexpress this receptor. Herceptin is used alongside chemotherapy and radiotherapy, and treatment duration is 1 year. And finally, for adjuvant treatments, we've all heard about bisphosphonates. Now, these are prescribed primarily to manage treatment-induced bone loss, but interestingly, data has shown that bisphosphonate use is associated with reduced bone recurrence and breast cancer mortality. So it's now recommended for postmenopausal women at higher risk of recurrence, for example, those with node-positive disease. Now, I didn't know that before I dived into the Pearl, so that was a learning point for me. Now, what can you tell us about follow-up and ongoing care following breast cancer treatment, Lucy?
So it's changed, basically. For many women in recent years, breast cancer follow-up has moved from secondary care to patient-led monitoring with primary care support. So it involves us, basically. High-risk women may stay under secondary care, and different localities may have different pathways agreed between primary and secondary care. But essentially, at the end of the initial active treatment, so that's surgery, chemotherapy, radiotherapy, immunotherapy, patients will be issued with a care plan which is shared with primary care, and it should give us advice on how to support them on an ongoing basis. So it should include dates for review and duration of adjuvant endocrine therapy so that we know exactly what is expected of us.
Yes, and I've got a top tip regarding this.
Oh, tell me.
Well, it's useful to add review and duration of adjuvant endocrine therapy as duration and indication prescribing. So, for example, if you're prescribing tamoxifen, then in the directions you put 20 milligrams daily to reduce the risk of breast cancer recurrence, take for 5 years, review March 2030. So, hopefully that will be helpful. Sorry, Lucy, I interrupted you. What else should be on the care plan?
So as well as the dates for review and duration of adjuvant endocrine therapy, there should be details of surveillance mammography, information about any symptoms or signs of recurrence or treatment side effects, including those related to estrogen deficiency, so things like menopausal symptoms and osteoporosis, and contact/referral details for specialist support services if problems arise, including a pathway for women experiencing menopausal symptoms. Once received, this information should support cancer care reviews and medication reviews going forward.
And by the sound of it, it should help to make our consultations in primary care easier. So let's talk side effects of these adjuvant treatments now. The menopausal symptoms induced by adjuvant treatments tend to occur within a few months of starting treatment and can be more problematic and long-lasting than those associated with natural menopause. These symptoms may be overlooked by healthcare professionals who might primarily focus on cancer outcomes, and yet many women consider stopping their treatment due to side effects for which management has never even been discussed. Lucy, how do we get better at this? What should we be asking about?
Common side effects that we should ask about or consider asking patients about are vasomotor symptoms, vaginal symptoms, and sexual dysfunction. We should also be thinking about endometrial cancer risk, any musculoskeletal symptoms, and we should ask about amenorrhea, which may be suggestive of premature menopause. Starting with vasomotor symptoms. So in premenopausal women, symptoms following chemotherapy or GnRH-induced ovarian suppression are usually more severe than those associated with tamoxifen. And actually, the persistence of symptoms following cessation of tamoxifen is likely to be due to early menopause induced by previous chemotherapy. In postmenopausal women, both tamoxifen and aromatase inhibitors are associated with vasomotor symptoms, but severity may reduce with time. Let's move on now to vaginal symptoms and sexual dysfunction. And we should always ask about sexual issues because patients may not raise them without being prompted. So iatrogenic ovarian suppression, tamoxifen and aromatase inhibitors are all associated with genitourinary symptoms and may lead to vaginal dryness, dyspareunia and reduced sexual desire. Some women actually may notice that they experience increased vaginal discharge on tamoxifen, and this is due to it having an estrogenic effect on the cervix and vagina. And remember as well that chemotherapy may adversely affect sexual function more broadly due to hair loss, fatigue, weight gain, and just the negative body image that a woman may develop as a result of having the treatment. Moving on now to endometrial cancer risk. So tamoxifen is associated with a small increase in endometrial cancer risk, but only in postmenopausal women, and that's due to its estrogen stimulatory effect. It does not appear to increase risk in premenopausal women. Aromatase inhibitors, on the other hand, have either a neutral or reduced risk of endometrial cancer. So do you want to talk to us a bit about the musculoskeletal symptoms, Nick?
Yes, of course. So symptoms such as morning stiffness, pain in the hands, knees, hips, the back, the shoulders as well, affect about half of women treated with aromatase inhibitors, especially if they've had taxane-based chemo. Now, it's thought to be due to estrogen deprivation, inflammatory pathways, and fluid retention. Finally, let's think about amenorrhea. Chemotherapy suppresses ovarian function, resulting in amenorrhea, which may be permanent. It can increase the likelihood of early menopause, and this is higher in women over the age of 40 and with certain regimes. For example, alkylating agents are more gonadotoxic than taxanes. Most women who resume menstrual bleeding do so within 2 years of completing chemotherapy, but it can take up to 5 years. Tamoxifen may be associated with a small increased risk of early menopause. GnRH agonists cause only temporary ovarian suppression, and if given with chemotherapy, they appear to reduce the risk of chemotherapy-induced premature ovarian insufficiency.
And to clarify, that's in premenopausally aged women with breast cancer rather than postmenopausal women who may be naturally amenorrheic.
Yes, absolutely. So how do we actually help these women who have menopausal symptoms with a history of breast cancer? Let's go through the British Menopause Society's recommendations. You'll see that as a general rule, we should discuss lifestyle changes and non-hormonal treatments first line. In postmenopausal women, switching from an aromatase inhibitor to tamoxifen may alleviate menopausal symptoms, but this should only be done in discussion with the breast specialist or oncologist.
For vasomotor symptoms, as Nick just said, we should start with lifestyle measures. So things like portable fans, dressing in easily shed layers, weight loss, avoiding triggers like spicy food and alcohol. Non-hormonal medications include SSRIs, SNRIs, clonidine, and gabapentin or pregabalin. But remember, the last two are controlled drugs. Some data supports mild to moderate efficacy with these medications, but we should counsel our patients about side effects if we prescribe them. We also, and this is very important, we also need to avoid paroxetine and fluoxetine in women on tamoxifen due to their inhibitory effect on tamoxifen. So venlafaxine 75 milligrams is recommended by the BMS for patients taking tamoxifen.
Yes, absolutely. Psychological therapies now, and these would include relaxation therapy or mindfulness. CBT and other behaviour-based therapy may be useful in coping with symptoms. CBT can alleviate low mood or anxiety related to the menopause. Complementary therapies are tricky. The absence of regulation means that these products can vary in their constituent ingredients, and furthermore, there's little clinical data supporting safety or efficacy. Most are therefore not recommended. Some can interact with cancer treatments, for example, St. John's wort, which should be avoided in women on tamoxifen or docetaxel.
Remember also red clover, soy, black cohosh, vitamin E, magnetic devices and bioidentical hormones are not recommended and should be avoided in all women with a history of breast cancer. Research is ongoing looking at other alternatives such as acupuncture, neurokinin 3 receptor antagonists and oxybutynin, so these might potentially be future options for our patients. So moving on to genitourinary symptoms now and sexual dysfunction. In terms of management, first-line treatment would be supportive advice. So we should consider offering psychosexual counselling if that's available locally. Some patients may benefit from using vaginal dilators or learning how to do pelvic floor relaxation techniques, and actually referral to a women's health physio can be really helpful for this. And also there is the option of referring for psychological support more generally surrounding body image if that is an issue regarding the sexual problems. In terms of vaginal dryness and dyspareunia, vaginal moisturizer and lubricants are first line. There have been some suggestions that paraben-containing preparations, that's things like KY jelly, Replens, Astroglide, are estrogenic, but that hasn't been backed up by evidence. So women can use the vaginal moisturizer or lubricant of choice, and they might want to try a few before finding one that they like. So if symptoms persist after a trial of first-line treatments, NICE say that low-dose topical estrogens may be considered in women with a history of breast cancer unless she is taking an aromatase inhibitor. And NICE do suggest that this is something we could initiate in primary care, although the British Menopause Society recommends specialist advice or liaising with a specialist before starting a vaginal estrogen in a woman with a history of breast cancer. But there is actually no clinical data confirming safety of vaginal estrogens in women with a history of breast cancer. There's only been 4 trials that have looked at it, and they all had methodological flaws. But NICE feel that because the amount of estrogen absorbed systemically from the vagina is actually very low, they feel that it's unlikely that vaginal estrogens are going to be harmful, or enough estrogen is going to be absorbed in that way for it to be harmful to women. So NICE states that vaginal estrogens are likely to be safe in women with a history of an estrogen receptor negative tumour. It says the risk associated with topical estrogen use in women with a history of estrogen receptor positive tumour is unknown. But in women on tamoxifen, the use of vaginal estrogens is likely to be safe. However, we should not prescribe vaginal estrogens for women on aromatase inhibitors due to potential systemic absorption of estrogen, which then negates the effect of treatment. So in that scenario, if a woman is on a aromatase inhibitor, we should refer to a specialist for advice, and they may consider switching her from an aromatase inhibitor to tamoxifen, but that's a specialist decision. So moving on now to musculoskeletal symptoms, what can we offer there, Nick?
Well, lifestyle advice, as we've said, is first line. So things like exercise, yoga, weight loss, paracetamol, non-steroidal anti-inflammatories, they're all in there. If symptoms persist, then switching between aromatase inhibitors or to tamoxifen can be considered. But just as Lucy said, that would only be done by a specialist. Now then, the question that we may have been asked, and we also all want the answer to, can women with a history of breast cancer ever be prescribed HRT? Lucy?
The British Menopause Society's position on this is that in exceptional cases, women with a history of breast cancer may be prescribed HRT if they have severe symptoms and other treatments have failed. This decision should be agreed with the patient's specialist breast team, and the patient should be fully counselled and consented regarding the risk and the off-licence nature of this prescribing, and all this should be documented. Sometimes we do see patients who are no longer under the care of a breast team. So in that scenario, we should liaise still with the local breast unit for advice and onward referral. And we should remember that HRT should not be prescribed to women taking aromatase inhibitors in the same way as vaginal estrogens shouldn't be prescribed. And again, that is something where a breast cancer specialist may consider switching her to something else, so tamoxifen, in order to be able to use HRT. But as I say, this is not a decision that's made in primary care. It's one that does need a lot of thought, a lot of counselling, a lot of discussion prior to initiation of a hormonal therapy.
Absolutely. In its breast cancer guidance, NICE concurs that HRT may be offered to women with severe symptoms following a discussion of the risks, and that's from NG 101 from 2018, updated in 2025. So, as Lucy was saying, this is not a decision that we should take in primary care. HRT is generally contraindicated, but not absolutely. Decisions must be individualised with specialist input. If you want to understand more, or if you work as a clinician with a special interest in menopause, then there's more detail on this in the Written Pearl and associated article on Redwell Knowledge. The bottom line is that there is limited trial data looking at the safety of topical or systemic HRT in women with a history of breast cancer, and some of the studies that have been done were stopped prematurely due to concerns about safety. There's a summary of the existing data in the Written Pearl if you'd like to read it. So let's finish off by touching on fertility and contraception.
The impact of breast cancer treatment on fertility should be discussed at diagnosis, and some women may opt to have their eggs harvested and frozen prior to initiating their treatment. Remember, hormonal contraception is generally contraindicated in women with a history of breast cancer, but oral emergency contraception may be used in a scenario where it's required, as it's unlikely to be harmful. The College of Sexual and Reproductive Health recommends the copper IUD or sterilisation as first-line contraceptive options for women with a history of breast cancer. It is not possible to predict which women have been rendered infertile by breast cancer treatment, so the College of Sexual and Reproductive Health also gives guidance on when contraception is no longer required. And for more information on that, see our article on contraception following a diagnosis of breast and other cancers. So just before Nick wraps things up with your learning points, I have a take action point for you. If you are seeing women with a history of breast cancer, do not wait for them to bring up these symptoms we've been talking about. Remember to ask. Open the door to these conversations, and if you're unsure, reach out to your local menopause or breast team for advice. I know that sometimes in primary care it can feel you're a bit isolated, but you're not in this alone.
Absolutely. It's all about supporting women through a really tough time and making sure that they get the best possible care. And hopefully you've got a framework to help you with this now. So here are your learning points for managing menopause after a diagnosis of breast cancer. Ask about menopausal symptoms and treatment side effects. Just discussing them can be therapeutic.
First-line management is lifestyle advice and non-hormonal medications. HRT is generally contraindicated unless symptoms are severe and other treatments have failed, and this is a specialist decision.
Fertility after breast cancer treatment is unpredictable. Recommend non-hormonal contraception and discuss options early. And that's the end of our first Pearl. And Lucy, thanks for joining us today. And you've just launched the Menopause Masterclass, haven't you?
Yes, we have. So that's a one-day on-demand online course, which is an in-depth teaching and discussion on some of the trickier areas of menopause, which may be something that GPs with an interest in menopause or an interest in women's health may see in their clinical practice. So dealing with women with a history of cardiovascular disease, women with a history of VTE. There's a whole day worth of all the sort of common tricky scenarios that we might experience or might see in our menopause clinics or in our menopause consultations.
Excellent. And what would be your favourite part of the course?
So all the bits that you're in, Nick, obviously.
Obviously.
But actually, we do a really, obviously, but we do a really good section, I think, on how to manage patients who are not responding to their HRT or who are on off-licensed regimes and how to manage that and what to do about that. And also there's a really good section on the utility of measuring estradiol levels. So I think that's my favourite bit, but it's a very comprehensive course. So if anyone's interested in menopause or wants to have just a bit more support in managing more tricky menopause, then please do have a look at it.
Fabulous. Thank you, Lucy. And thank you for being with us today. And I'm sure that in the very near future, we will be calling on you again to come back and talk to us about another women's health issue.
I hope so, Nick.
Cool. You take care and see you soon. Take care. Bye-bye. Are you a GP trainee or do you know one? We've got some exciting news.
We know that GP trainee years can feel daunting and expensive. So Redwell has joined forces with the MDU to provide a free education package tailored to GP trainees, which has been really popular. Nick, can you tell us about it?
Of course, this is the GP Trainee Essential Support Package, exclusively available to GP ST MDU members and affiliates. It's worth £165 and is designed to build your knowledge and confidence to help you pass your exams. So what does it include, Fee?
You get access to the whole of Redwell knowledge. That's over 900 written resources to support you during consultations and with exam preparation. Some of you describe it as like having an educational supervisor in your pocket. There's also a digital Top AKT Topics handbook, which contains topics that the RCGP says people find challenging in exams.
You also get access to 4 on-demand exam preparation webinars that demystify workplace-based assessment, AKT, SCA, as well as statistics and data interpretation.
And from August 2025, we'll be sharing a monthly video bite on common primary care presentations to support your learning even more.
So, who's eligible and how do they access it?
This all depends on where you are training. If you're a GP trainee in England, indemnity is provided through your deanery, but in addition to this, you can sign up for free MDU affiliate membership anytime during your training. You will then be able to access the GP Trainee Essential Support Package for free. And if you're a GP trainee in Scotland, Northern Ireland or Wales, you choose and pay for your own indemnity. Therefore, if you choose the MDU as your indemnity provider, then you will gain free access to the GP Trainee Essential Support Package. Just visit themdu.com to find out more. Click Choose to Join MDU and you can see all the options.
Once you're signed up, you'll receive a code from the MDU so that you can access GP Trainee Essentials as a free member benefit. And when you CCT, if you choose to continue with MDU indemnity, then you'll get a free Redwell course of your choice or a discount on Redwell Unlimited to support you in your first year of practice. So, if this is of interest to you, then see the link in the show notes for full information and T's and C's, or search Redwell GP Trainee Essentials to learn more. And here's Fee now with the Redwell calendar for November 2025 and beyond into 2026.
So we've got lots coming up over the next few weeks. So some things sooner for your diary and some things to plan for. You can join Susan on Thursday the 20th of November digitally for the Urgent and On the Day Care course. You can also join her on Saturday the 22nd of November for GP Update. And then if Women's Health is on your PDP, join us on Friday the 28th with Helen and Lucy. And on the same day, you can join face-to-face for GP Update with Susan and Hussein, and also on Saturday the 29th too. And then if blood results is something that you feel you need to brush up on, join Catherine on Friday the 5th of December. And then looking forward to the new year, we've got the lifestyle course on Wednesday the 14th of January, live with Hussein. All dates are on our website.
Our next pearl is all about ultra-processed food. Joe Wicks recently released a documentary called Licence to Kill on Channel 4, and it's brought the topic of ultra-processed foods back into the spotlight. Now, whilst the scare tactic language in the title and also in the adverts on TV and on social media were perhaps not the best way to support people to make sustained change, the programme contains some important points and may well result in questions coming primary care's way. So I wanted to make sure that primary care was as well prepared for this as possible, and so I made a special episode of my podcast Boggle Docs, which is the podcast that equips you to be prepared for patients consulting about things that they might have seen or heard in the media. And we asked the question, was the documentary really as bad as social media would have us believe, or is there room for a more nuanced conversation about ultra-processed food? I was joined by Hussein Al-Zubaydi, who you will have heard on the Red Whale podcast, and is also the lifestyle medicine lead at Red Whale. So here is a segment from that episode which talks about the documentary and also the Red Whale ultra-processed food Pearl. And if you want to listen to the full episode, then there is a link in the show notes.
This is Boggled Dogs.
Red Whale have released a Pearl, which is some of their free content, free learning content for primary care. And this is to coincide with the release of the Joe Wicks documentary License to Kill. And their Pearl this time is all about ultra-processed food. Now, when we cover Pearls on the Red Whale Primary Care Pod, which I co-present as well, I always say about how long it took me to read that particular Pearl. So just to say that I've read the ultra-processed food Pearl, and it took me 11 minutes, 22 seconds to read. So kind of a medium length Pearl to read. And I think maybe this would be a good time then, Hussein, to actually to say or to ask what is ultra-processed food so that we can sort of start with firm foundations.
Yeah, and that's one of the initial challenges in the sense that there isn't a sort of universally agreed definition. Now, one that was defined in an article published in the BMJ in 2022 is industrial formulations made by deconstructing whole foods into chemical constituents, altering them and recombining them with additives into products that are alternatives to fresh and minimally processed foods. And, for example, freshly made meals. And we have different criteria in terms of processing. So in the NOVA food classification, now this was something developed by the Center of Epidemiological Studies at the University of Sao Paulo in Brazil, they have 4 groups, where group 4 at the sort of far end is our ultra-processed foods and what we just described before. And then right at group 1, we have unprocessed or minimally processed foods. So, for example, whole fruits, vegetables, nuts, eggs, etc. And then we have 2 middle groups. And this is often where we get kind of confusion as to what is an ultra-processed food and what isn't. In group 2, these are processed culinary ingredients. So the things like oils, fats, salts, and sugars. So many of the oils that we consume, for example, go through processing in order to stabilize them so we can use them for cooking. Things like butter, that they've undergone some processing from its original milk, for example. And then we have group 3, which is processed foods. So rather than processed culinary ingredients like group 2, these are processed foods, things like canned or bottled vegetables, canned fish, salted meat or fish, freshly made bread, etc. And what's really important to note is processing something does not make it bad. In many ways, it's massively helped us to help with preservation and transport. For example, canned chickpeas retain fantastic nutrient qualities and means that they can last for longer. They can be cheaper in terms of storage and selling. And so it's really important that we don't automatically vilify processing for the sake of it. And same even for ultra-processed foods. There are certain foods that have a number of health benefits when we ultra-process them. For example, fortifying them with things like B12.
Okay. Things like breakfast cereals.
Yeah, for example. And things with breakfast cereals, obviously it depends on the cereal and the other components within it. You'll get some on the far end, which are very high in sugar and fat, etc., while others will be much higher in fiber and lower in those sort of fats, salts and sugar.
Yeah, and some of it is about the marketing, and it's important to be aware that just because something's been fortified with a vitamin doesn't necessarily make it suddenly super healthy. But as you said, there are better ultra-processed foods than others. They're not all completely bad and should be demonized.
Precisely. And often what we get confused on is many of the ingredients behind it, some that we don't recognize. And yes, obviously ideal diet is one that consumes a lot of whole, fresh foods. But many of these additives in how they were portrayed in the program, we identified risk within them, for example, animal studies at very high doses. And what's really important, although they use the word linked in the documentary, what we have to be clear here is that the evidence is in association, because when we look at nutritional studies, it's very, very hard, if not impossible, to prove causation from these ingredients and additives for harm.
Exactly. And to pick up on that strand, there was a moment talking about a particular ingredient called aspartame. And Joe Wicks asked Professor Chris Van Tulleken about the research on aspartame. And Chris said that the WHO have issued a warning that aspartame is a class 2B carcinogen, to which Joe said, "What do you mean by carcinogen?" And then Chris said, "So it causes cancer." And so the World Health Organization say aspartame may cause cancer. Now, for me, that was interesting because when I'm watching documentaries like this, particularly when I'm going to talk about it on Boggle Docs, I love to dig a bit deeper. And so what they didn't make clear from the documentary is about these different carcinogens from the World Health Organization. Now, a group 2B carcinogen, the classification says possibly carcinogenic to humans, which isn't quite what Chris had said. And the other ones in that category would be things like pickled vegetables, and also aloe vera whole leaf extract as well, which are two things that possibly haven't really got a bad reputation.
I eat pickled vegetables all the time.
Well, precisely.
I'm slightly alarmed.
Yes. And I'm sure lots of us use aloe vera as well. So, these are things that they're out there and they don't have a bad reputation. And so group 2B is obviously below group 2A, and group 2A is probably carcinogenic to humans. And they talk about things like red meat in that group and also simply exposures from working in hairdressing. So that kind of puts the level of what they were talking about. And so it was interesting that they led us to believe, having watched that just on face value, that aspartame caused cancer. And actually, it's not quite as simple as that, is it?
Yeah. And I think both you and I have had, a fair bit of work in TV, sort of in media, and there is often the pressure to, what's the right word, but sort of sex up or they say clarity, but often really kind of press home something through the language that you use. And so I do wonder, I'm obviously assuming, I wonder if they were encouraged and advised to use terms like that without understanding that the language matters. As you very rightly said there, we putting it into context, using the right language of probable and possible is very different to it causes cancer. So I worry that many watching that will be unable to, understand and bridge that gap. And so you're going to create a lot of concern. And bear in mind, aspartame has only been recently added onto the possible. That was about a year and a half ago. And the evidence is relatively weak, and hence why they've popped it in that 2B group.
Yeah, and in fact, I remember you being on Steph's Pack Lunch talking about aspartame. And in fact, I remember actually you using the aloe vera as your analogy of it being in the same group.
Exactly. And on that show, I remember specifically, they were encouraging me to sort of up the kind of concern level. And I just pushed back and said, I'm not going to do that. What I want to do is I want to make sure that people leave this understanding what the evidence is showing. And they can make their decision based on the evidence rather than me trying to make it seem like it is more concerning than it is. And so there is a lot of pressure, and I think we do need to appreciate that and what the producers may have been trying to achieve rather than really solely placing the blame on the presenters and experts on the show.
Absolutely. And this is why we like to delve into this kind of stuff, because we're looking at all angles. We're looking at the nuanced arguments. We're not trying to cancel anybody. I think that they wanted to have the word carcinogenic in there because that was their headline. That's what they were trying to do. And if we take a step back, what they were actually trying to do, because they were making this protein bar, weren't they, which was meant to be highlighting the fact that you can have something that's marketed as healthy, but having lots of unhealthy ingredients in it, which combined together could possibly potentially cause harm, but the possibly potentially bit isn't headline grabbing. So they needed to just cut that bit out and have the causes harm, because that's what's going to grab people's attention. And at the beginning of the documentary, Joe Wicks basically said, diet is killing people. Isn't it the government's job to protect the health of the nation? And it's also mentioned in the Red Whale Pearl that this is a government level problem regarding ultra processed foods. So it's got us talking about it. It's got the nation talking about it.
Boggle Dogs.
Now, in our last episode, our £1 million question, though actually it's a virtual £1 million, so I'm sorry about that, was on cervical screening.
Yes, it was very exciting, actually. I did, I don't know if any listeners managed to do this, but I did vote on the Spotify poll. That was very clever, Nick, actually. I've got a top tip for listeners, though, because I went back to the poll after I'd listened to the episode. And actually, if you click through, you can get the transcript. And so you can see all the available options if you just scroll right down to the bottom of the episode. So all the options for the answers. Because I think being a medical podcast, all our answers are a bit too long, aren't they?
Yes, too long to write in. I did try very early on the Friday morning it was released. So yeah, we had to think again.
Yeah, it was good fun though. I quite liked it.
So did you get it right is the question?
Do you know what? I did actually, and I promise I didn't cheat. I didn't look up the answer first. But yes, I was very happy because a few years back, Nick, I was on your Boggled Docs podcast and I remember getting something wrong and I felt really ashamed about it.
Oh, bless. It's never wrong. It's always...
Well, it's always learning, isn't it? That's it.
Exactly. And I bet you
so what was the percentage of people that got it right?
That's a really good question. A third of listeners opted for option B, a third opted for option C, and a third opted for option D.
And D was the right answer, wasn't it?
And the correct answer, we said that last time, was D.
Okay, so a third of us got it right.
Yeah.
Well, although it's a third of people that voted, isn't it? Because actually people might have got it right and they didn't vote. So come on, guys, come on, team. I reckon we did a lot better than that. I don't think that's accurately showing our answers. So why don't you have a go at the poll if you've got access to Spotify? And you can just do it through a free account, can't you, Nick? So
exactly, yeah. So you don't need to
play
be
along.
subscribing. It's all fine. Just find the episode and it's
come
all
on,
there.
team. Yeah, I reckon we can do even better. And we probably did. We just maybe didn't use the poll or write in, because also you can send a message or a voice note, can't you, Nick? So okay, so another option this month. Nick, what have we got?
Okay, so your cliffhanger, as we know, is in the shape of the £1 million question, and you know how it works. To land the learning, you need to imagine that you are on the verge of winning a virtual £1 million. All your lifelines have gone. It's all down to this final question. It's all down to you. So let's dim the studio lights. And let's take a look at your question for a virtual £1 million. And as Fiona was saying, if you want to vote, then you can go to Spotify and you can also text us. Next time, we're covering addictive behaviours and impulse control disorders. So, for a virtual £1 million, here's your question. Impulse control disorders. A. Involve repeating a behaviour because it feels rewarding or reinforcing. B. Are driven by craving or compulsion, and stopping the behaviour may lead to withdrawal symptoms. C. Involve acting on sudden urges that bring short-term relief, excitement, or escape. D. Are usually seen across multiple contexts and situations. So, what's your final answer? And the answer is going to be revealed in next week's episode.
Ooh, that's a really tough one, I think.
Isn't it? Now, before we go, last month I was talking to Ali about her experience with Total Triage. So, Fee, how's it all going for you?
I'm not sure if I've got a one-word response. I would say unknown. Although when I was listening to you guys talking about it last time, I did think to myself, and this can sound really gushy, but I did think, do you know what? In primary care, we are a workforce that just gets on with it. You know, we get given all these different challenges, some of them totally out of our control, and whether or not these things will stay or not, and, you know, all the politics behind that, we just get on with it and we just do it. And I think that's a really great thing. So I'm very proud as well.
Yeah, absolutely. And people are, you know, they're running with this one, aren't they?
Yeah. But I really did like this, and we've had some great entries, haven't we? So should we read through those?
Yeah, so you might remember that we asked you to say who you are, where you are, and a one-word description of your experience of Total Triage.
So we've got annoyed, and that's sent in anonymously from someone in Pendle.
Matt GP from the Wirral. is nervous.
And another anonymous one says propaganda, brackets, companies making tools even they don't understand how the user experiences. That comes in from Chester.
Jamie GP, useful from Richmondshire.
That's good, yeah. I'm getting all the anonymous ones. Brief is that entry. Anonymous from Anonymous.
Okay, Thank you for being so mysterious. We've got Phil GP from Chester, and he says dangerous.
And Dr. Ali GP says scary, brackets for kids. That's from Yorkshire.
And finally, for this time, we have Sidra Hussain GP from Manchester, and their word is uncertainty, and then in brackets, trying to understand what people have written and how to manage.
Oh gosh, yeah. I think that's one of the hard things, isn't it? Sometimes is trying to decipher. So please do continue to send those in, because I think it will be interesting over the next few months as things settle in to see how everyone's getting on with it. And it's okay to not necessarily be positive.
Yes, see how those words evolve over time.
Yeah,
exactly.
Be honest.
So you can text us, email us, voice message us, whatever you'd like to do.
Yeah.
Okay, now if you're hankering after a Red Whale Knowledge subscription, then we're offering a 10% discount on Red Whale Knowledge for our fabulous Red Whale Pod members. How do you become a member, I hear you ask? Well, if you're listening to us, then you are part of our pod, so welcome to that. And all you have to do is go to redwhale.co.uk, put Red Whale Knowledge in your basket and enter the code RedWhalePod to get your 10% off. And here's the small print. The discount is only for this product and it won't work on anything else. And please also note that this voucher code is all one word and all lowercase, and it can only be used once. Red Whale Pod.
If you've enjoyed listening, which we hope you have, then please give us a 5-star rating on whichever platform you use. It only takes a few seconds and we'd really appreciate it. And if you could spend a little more time, then please leave us a nice review too. Because of the way the algorithms work, it means that other people just like you can discover us.
And of course, putting algorithms to the side, there is no greater recommendation than a word of mouth recommendation. So if you've got some value from listening to the podcast today, then don't keep it a secret. Please tell everybody that you know who might also benefit from listening. All the resources that you need are in the show notes, and all the links are in the show description on your preferred podcast platform.
You can also find us on social media. We're on Facebook, Instagram, LinkedIn and X. If you want to see something about the podcast, then please use the hashtag RedWhalePod.
And the other thing that you can do if you click on the link in the bio is to leave us a voice message telling us about anything that you found helpful or would like us to go over.
You can also email us. Our address is podcast@red-whale.co.uk. And remember, we also have impact@red-whale.co.uk for all the changes that you're making down on the ground. Until next time, I'm Fiona Ritchie.
And I'm Nick Kendrew.
Remember to keep Red Whale Knowledge open on your desktop at work, so we're with you when you need that bit of extra information or reassurance.
Take care and look after yourself. Bye-bye.
Bye.